moving on to the next subject. A quick starter here then. How many of you routinely engage in external cephalic version at your institution? When I mean your institution does perform these. Just want to get a real. So it looks like probably 80% of the room. How many of you routinely, as part of your practice, employ a neuraxial anesthetic technique as part of that? Maybe about half, 40 to 50% of that group. All right, so I think the opening segment I want to talk to you about, we talk in obstetric anesthesia that, or at least the debate that formed in the 80s and 90s is at the time when we had a concern that what we might be doing might affect cesarean delivery rates. I think that was generally disproven in our field. We know that our choices about local anesthetic concentration and dosing clearly affect second stage and can influence instrumental delivery rates, particularly in the nulliparous patient. But almost nothing that we do in terms of labor analgesia can affect cesarean delivery rates. I'm going to touch on a topic as one of the few things you can do in anesthetic practice that actually affects cesarean delivery rates and show you the data around it. No conflicts, but intrathecal opioids and terbutaline for tocolysis are off-label uses of these. I'm going to talk a little bit about breech presentation and what's happened over the last 20 years that has changed the landscape in obstetrics. Talk about ECV, external cephalic version, what factors improve the likelihood of it, including your participation in this. Talk a little bit about some of the dose-response dynamics and present data from a trial that we've just finished and is in publication, and talk a little bit about broader subjects like resource utilization and logistics. So the U.S. cesarean delivery rate as of a few years ago, and I think this is pretty stable, is 33%. This does represent a 50% increase over 10 years, and according to experts in our field, that 50% increase did not occur with any concurrent benefit in maternal or neonatal outcomes. In fact, if anything, it probably suggests a deterioration in some outcomes for the mother particularly. I think that we saw that this morning, that this ideal line of optimal cesarean delivery rate, we seem to be well past. What are our strategies to address that? Well, this is one of them. This is cesarean delivery rates over the last, what is that now, 20-some years, I guess up until maybe 5 to 10 years ago now. There's an inflection point, if you see it there, around the year 2000 where things really seem to take off and bounce and essentially represent this 50% increase. What was that jump? Well, a lot of it was this. A lot of it was the way we managed breech vaginal deliveries. And it had to do with the way the obstetric community interpreted the Hanna paper. The Hanna paper, published in the Lancet in the year 2000, randomized over 2,000 women to have either an elective cesarean delivery for breech or have a planned vaginal delivery. The primary outcome was a composite one, that was neonatal death or serious morbidity, and that was the outcome you see there, a significant difference. If you went straight to cesarean delivery, it seemed to have a protective effect in terms of this composite outcome. Whereas breech vaginal delivery now seemed irresponsible in light of these data to conduct, with the exception of extreme circumstances such as advanced dilation in someone who is parous. But the interesting, and it did lead the ACOG to come out with this committee opinion that strongly suggested that singleton breech delivery should go to elective cesarean. Funny thing happened though, is that 2 years later, when you looked at these children, the way neonatal death obviously was a fixed outcome, but neonatal morbidity, and the significant contributor to that composite outcome, when you reevaluated these kids at 2 years, they really didn't look much different. There was no difference in these kids. But the problem is several years had passed in this interim, and practice had changed, and obstetricians' opinions about the risks associated with breech delivery seemed somewhat fixed. In fact, a half a decade had gone by where at least the next generation training wasn't getting the same experiences in this. And I would say that certainly in my institution that hasn't changed. Now, 17 years after the Hanna paper has been identified, we almost never do vaginal breech deliveries despite that follow-on paper reevaluating the real risk. So practice changed dramatically, and it contributed to this public health crisis that we know about in the United States, and that is the very high cesarean delivery rate. So external cephalic version offers one of the opportunities to address and reduce this very high rate. It is a manipulation of the infant transabdominally. I have to say the first time I saw this in practice, it did feel a little medieval to me in terms of modern medicine. But it is on several lists of top ways to reduce your cesarean delivery rate, and it's one that you can actually participate in. So this represents 3.8% of pregnancies, but because of the compounding effect of multiple pregnancies and incomplete compliance with TOLAC strategies, it ends up contributing to 6 to 8% of total cesarean deliveries. Success rates in turning babies is widely variable based on institution, individuals, but there's several factors that can predict outcome. If you're thoughtful, you can choose those that are easy to turn. We do know that tocolysis substantially improves the success of this, and what I want to talk a little bit about is anesthetic applications. In terms of the priorities in this, oh yes, I did have Leonardo da Vinci's beautiful drawing of breech presentation from the 1500s here. I did have a drawing that I found when my mother died of my representation of breech presentation in 1968. This is my younger sister. It turned out to be Vertex, just so you know. Here are the priorities. It is funny, kids, it's very unusual to think of a kid upside down as a passenger, isn't it? Maternal safety, baby safety, improving the success rate of both the procedure and then subsequently reducing the cesarean delivery rate. But there's some other considerations here, the maternal experience itself. The timing of breech external cephalic version tries to take advantage of this optimal cross-section between when a child, the likelihood of spontaneous version is reduced. This is the likelihood of breech presentation over the course of gestation. Obviously, once the amount of space in the uterus starts to become diminished, the kid becomes more fixed. That starts to flatten out once you get to term. If you also know that there is a small likelihood of having to do an emergent cesarean delivery during one of these procedures. It probably represents a likelihood of about 1 in 200, so that you don't want to deliver someone too early in terms of delivering an immature and developing some lung morbidity associated with that. But you also don't want to turn a kid so early that the likelihood of spontaneous reversion occurs. So there is some optimal timing question here. A large randomized controlled trial in Canada addressed this, 1,500 breech patients randomized to either an early or a term breech, 34 to 36 weeks versus 37 plus. Primary outcome, not the surrogate measure of increased procedure success that many of us have done trials in this shoot for, but really the more meaningful one, and that is cesarean delivery rate. As you can see, there was an improved success rate in turning these children in the earlier group, but it did not translate, at least in the power of this study, to be a substantially lower cesarean delivery rate. Counterintuitively, there actually was a higher neonatal morbidity rate in the group that had the delayed version, not the early version. It related to two cases. I think when you start looking at secondary outcome variables, the likelihood that one happens spontaneously, and in this case counterintuitively, is not that unlikely. There are 5 international guidelines that exist out there with regarding to are there any contraindications to this procedure. They all contain slightly different things. I think the bottom line is there are all relative but not absolute contraindications to this procedure. What are the safety? Almost all feel heart rates change during a procedure when you're pressing hard on the abdomen. frequently with transient bradycardia, really persistent fetal heart rate anomalies, and other causes for having to do a cesarean delivery within 24 hours are caused by persistent bradycardia or some sense of abruption. The emergent cesarean delivery rate, as I'm quoting here, is about a 1 in 200. More importantly, those are the incidence of some of those complications. The real question you want answered as a patient facing this is, what is my likelihood of having an adverse neonatal outcome if I do this or not? And reassuringly, we published at our institution data on approximately, I can't remember if this is about 3,000 patients, those that had versions versus those that refused to have versions, and it seemed like across a broad spectrum of neonatal morbidity, the outcomes were about the same, which is quite reassuring to someone who's willing to take on an additional procedure to reduce the risk of cesarean delivery, of which, by the way, I might add, many people are quite satisfied to have a reason for an elective cesarean delivery. Predictors of success include the following list. There are fairly good and among some of the largest forest plots in terms of total number of studies to support these. If the kid is already, once the head starts to become engaged, it's harder to term them. If you're a Paris patient, your uterus is thinner and it's easy to rotate a baby. If the placenta is not in your way, that makes it easier. Transverse implies that you're already halfway there. That's an easy version. In fact, if anything, that can confound a lot of the trials that we've published in that realm. And if you're thin, that helps. There probably is a very broad difference in experience between obstetricians. We have at our place what we refer to as good flippers and probably bad flippers, I guess. Maybe a lot of average ones. You absolutely should be employing a tocolytic effect, but the odds ratio with its employment are substantially better than if you don't. There are a fair number of randomized controlled trials about what you should use to tocalize. Calcium channel blocker is the only one that's been shown not to work. I think most people are satisfied using either a beta agonist or nitroglycerin. My recommendation for nitroglycerin is counter to the 3 trials published in this, but all 3 of them had problematic design in terms of evaluating the outcome that happened beyond what I think many of us would consider the duration of a nitroglycerin dose for tocolysis. If you're looking at a tocolytic effect beyond 10 minutes, you probably aren't being very thoughtful about your pharmacology. The options. So I suggest from, let's see, at least half of you are probably either doing in this room nothing or some intravenous opioid analgesic intervention. The rest of you are doing some form of neuraxial technique that you have choices, and people is pretty split on what people do for this, both in terms of the technique itself and how they dose it. Are you dosing it for an analgesic effect or an anesthetic effect? The trial that we did initially, we chose an analgesic effect, but we thought it would optimize the maternal experience, but not such profound numbness and relaxation that perhaps the theoretical concern of an OB pushing too hard and shearing the placenta off the uterus and creating abruption and an adverse outcome would be there. I'll go over some of the data related to that. These are more painful than you may think. If you aren't somebody that participates in doing these, you probably haven't seen them too much. I described for you, I thought they were a little bit on the medieval side. The pain experiences in terms of numbers are represented here, both split by in dark bars by those that had successful versions and slightly lower pain scores versus those that had failed turns and not surprisingly slightly higher pain scores. So these are painful procedures. However, they're transient. And they also are ambulatory, which affects the way we look at things to some degree. Can you do these with systemic opioids? Obviously, many of you do. That was our standard practice before our first trial at our institution. Probably the best drug for this, one could argue, is remifentanil. Recent trial published by Dr. Munoz from Spain, randomizing women to either remifentanil in the doses I've shown you there versus a control, no opioid, demonstrated a general trend towards, I should say, well, they demonstrated no difference. You can see a difference in percentages in their success rate, but they did not reach statistical significance, substantially underpowered if there was a difference here, and no difference really in cesarean delivery rate. The pain scores are about what you'd expect. that we would see in terms of the impact of remifentanil analgesia on a labor experience, dropping the pain scores down perhaps 2 on average. So moderately effective in terms of the maternal experience, but not very effective in terms of improving the success rate. As I mentioned to you, employing a neuraxial technique has the benefit of both improving pain and satisfaction for the mother. It does have the benefit if you are one of those 1 in 200 that you need to do a cesarean delivery that day, in some cases on the urgent side, that you have a technique in place that you could extend if you chose an analgesic technique to an anesthetic one. But I will show you the evidence behind why I think this contributes to increased procedural success and ultimately reduced cesarean deliveries. I'll go over some of these other logistical considerations along the way. In our first trial at Northwestern, these are the data we presented in terms of patients who received an analgesic CSE in the open box plots versus the crosshatch, which was a systemic opioid comparative group, 50 mics of IV fentanyl. The maternal pain scores were substantially lower and the satisfaction higher. And by the way, that wasn't influenced dramatically by the success of the procedure, which you had thought of in terms of the satisfaction score. As I mentioned to you, the range of reported success for the likelihood of turning a baby with this procedure is really wide. Some of the reasons there has been heterogeneity reported in existing trials is that some included transverse lie in these. In the end, as I mentioned, ECV Success, which almost all of us who did these trials powered our investigations for acknowledging that this was a surrogate measure for ultimately cesarean delivery, which is the real interest. We noticed over the course of a few of these trials being published that there appeared to be a dose-response effect. That is, that those people that chose to do analgesic techniques, and I was one of them, and I told you the rationale behind it, seemed to not have the effect in increasing the success compared to those that chose surgical dosing like we do for cesarean deliveries, or approaching doses that we'd use in cesarean deliveries. The theory behind why any of this would work, but perhaps why higher doses might work, was mainly related to abdominal wall relaxation, specifically, skeletal muscle relaxation. But it also was felt that maybe just women tolerated you pushing harder. And as I mentioned to you, that may or may not have been a great idea. And generally, most of us thought that it allowed you to push harder. It turned out in examining this that the top 2 were right, but the latter was actually incorrect. A sophisticated study out of Alexia's group in Singapore showed that using piezoelectric pressure sensing crystals on the hands of the obstetrician doing the turns actually demonstrated that if you did a neuraxial anesthetic technique, you actually did not have to push as hard to get the same effects. A very nice study that their group did. Of the low-dose technique randomized controlled trials, these are the 2 that were out there, Lorraine Dugoff's and mine, choosing doses that this looks probably what many of you would have done in terms of labor analgesia. Maybe Lorraine Dugoff's, nobody's using those high-dose sufentanil anymore, probably not many people using sufentanil at all. But both of our trials, her trial was absolutely no difference between the 2 groups. Mine looked like it was underpowered to show a difference that was there. But the differences that we saw, if you chose both of Carolyn Weiniger's studies out of Jerusalem showed real benefit of this, of choosing a spinal bupivacaine dose of 7.5 milligrams, something that's on the lower end of what some people do cesarean deliveries with. Nice success rates in both nulliparous and paris patients. 2 subsequent papers that also existed out there using epidurals dosed like they were for a cesarean delivery with significant differences in outcomes. So if you put all of this together in ECV Success, clearly the sum total of all these studies showed a beneficial effect in terms of procedural success. And as I think it's often important to look at if there's any evidence of publication bias, there was a nice symmetric spread on a funnel plot suggesting that people weren't bearing papers either as authors or editors if there were negative results. I put this in our first paper, the dose-response effect that we thought we observed. If you pooled all those papers, and this at the time was missing Carolyn Weiniger's second study, it appeared that those investigations that shows a surgical strength here had a significant increased success rate in procedural success compared to mine and Lorraine Dugoff's that were analgesic. The overall forest plot was still a benefit, but this clearly was some observed dose-response effect that we saw at the time. In fact, there were 2 other unpublished trials. There were also analgesic doses that also ended up negative, never ended up published, but seemed to support that dose-response hypothesis. At the time of Getzinger's publication, this was in the Green Journal, so most of the anesthetic trials in this realm were published in anesthetic journals, but this meta-analysis was published in the Green Journal, the highest impact obstetric journal. Obstetricians read this and concluded, unfortunately I think falsely at the time, that you can do this technique, the maternal experience is better, and you'll be more likely to flip them, but at that time, and missing one final investigation, the diamond was still crossing parity, suggesting that it's really not doing what you really want, that is to improve cesarean delivery. Most of us had the sense that maybe 1 or 2 more trials and then you would have a statistical difference here. But unfortunately, a lot of the obstetric community in 2011 heard this message. It's not ultimately going to change your cesarean delivery rate. We have subsequently published that it does appear, there have been subsequent trials, including one more of our own. There is a statistical difference both in procedural success rate. It appears to increase your ECV success rate by 15%, and ultimately can reduce your cesarean delivery rate by 9%. So there's very few things that we do. That's just the difference between us being involved, no analgesia or IV opioids, and you not involved, versus you involved, dropping cesarean delivery rate in this patient population by 9%. It's a pretty powerful contribution by our specialty. Jumping ahead a little bit here. That observed dose response effect that I showed you on a forest plot at the end of our last trial clearly inspired a follow-on one. There must be some optimal dose then that is observed here. In fact, we chose our existing dose in their first trial, an intermediate dose, Carolyn Weininger's dose, and even went one beyond it. Maybe there's an ability to even further increase the success rate and reduction in cesarean delivery. We finished this trial recently. It's in publication. I'll show you the results. Unfortunately, this is one of those cases of a beautiful hypothesis slain by data. Entirely the same outcomes in every group. It was a little bit shocking when we opened the results. I thought there might be a ceiling effect, but I clearly was expecting some observed dose-response effect. How does one explain such a thing? One could only say there's certainly a lot of difference between each of our institutions. This was the first one that was comparing different techniques at a single institution with the same providers, and it clearly didn't make any difference. There's also were some limitations in the setting of doing these trials that allocation concealment was a little problematic. It's hard to do one of these trials and blind it properly. The first 10 patients I did in my first trial, we did sham catheters, but in the end, both the blinding was a failed blinding even in the sham catheters. The patients tended to tell their obstetricians what group they got assigned to, and OBs pretty much could tell the difference between no neuraxial technique or a neuraxial technique. However, this group, we felt that the OBs were fairly blinded to group assignment. Specifically, even though I thought that we're pretty good at identifying those that had complete motor blockade versus those that had heavy legs, for the most part, most of our Bs didn't quite pick up on that to some degree. We felt it was blinded to a greater degree. They knew their patients were comfortable. But in the end, this didn't dramatically, the dose response effect wasn't there. The key message, though, here was that this was still improving the success rate versus a non-neuraxial technique by 15% and reducing the cesarean delivery by 9%. As far as optimal dose, one of the questions that came out, I think, in the discussion of this, so of these doses, do you still pick them the lowest dose? That is our practice. We continue to use the lower dose. Some of it had to do with some of the side effects. There was a very marginal increase in benefit from 2.5 to 5 milligrams in terms of maternal experience, but most felt it wasn't clinically significant. We did see increasing hypotension as we went up in this table showing in each of the 4 groups the likelihood of hypotension. Granted, you could probably eliminate that with a phenylephrine infusion, a prophylactic infusion, which probably I suspect many of you do in your cesarean deliveries. We decided, I was outvoted at the design trial meeting. Thought that would be a little bit too complicated to do in an LDR. In retrospect, almost certainly we should have done it. In this range of hypotension and what people have observed in doing these types of experiences, our first trial was the 63%, the upper end. We are particularly bad at, I was going to say, in tilt. But the difference between this procedure and cesarean delivery is you're actually pressing the uterus down on cava. It is a little bit different, and we see, and it's also not in a laboring patient that might have some vasopressor effect from their own circulating catecholamines. The hypotension incidence is quite high in this group. To answer the question about do you see more crash sections, whether you would do neuraxial anesthesia versus systemic opioid or nothing, reassuring but not absolutely supportive of the safety were the fact that there were very few crash cesarean deliveries in all of these trials and an equal number in both groups, or near equal number, I should say. What about the logistics of this? Where do you do it? Many of you probably in your labor and delivery suite are challenged by having few operating rooms available for cesarean deliveries, and you're probably trying to handle both your elective cesareans alongside your emergent ones. I would say probably, actually I don't know exactly what percent of people do these in their operating rooms, but a fair number of people do them in their operating room. We tended to do them in our labor and delivery suites. That's always where we had done it. As we started doing neuraxial procedures that were analgesic dose, that didn't feel any different to us than doing labor analgesic in a labor room. However, people started to get a little skittish when we were doing these high dose ones in labor rooms. It required presence continuously, which was pretty resource intensive, and remains one of the arguments for why we think the lower dose is beneficial, particularly if you're not getting any additional procedural success benefit from it. The other piece of this, I think Katie Arndt at Mayo does these in the operating room, and she feels to some degree doing them in the operating room that they have a high likelihood of going right to cesarean delivery the same day. And she said some of it feels to her like maybe it's the realm of if you go to a barber, you get a haircut. If you go to the operating room and you prep everything for an emergent cesarean delivery, you do a version, the likelihood for an OB to make a decision to cut when they're standing there and all the equipment's there and it looks like he or she should be doing a cesarean delivery, then why don't you cut? That's her theory anyway. How about cost effectiveness of this? The Stanford group did a little bit of work on this in the last decade, generally demonstrating that doing an ECV's procedure itself, bringing a woman in for an outpatient procedure at term pregnancy, is moderately expensive. It probably is justified if you have an over 32% success rate in turning your babies, and almost everybody has that. The question is, we're an expensive intervention. What is the cost effectiveness ratio if the benefit if we add our expensive service to that? The threshold, at least in Brendan Carvalho's work, seemed to suggest that if you are at least getting an 11% benefit from your neuraxial technique and the overall meta-analysis shows 15%, then our intervention is probably, our participation is probably justified. So in conclusion, you should absolutely be doing tocolysis with this, beta-2 or even nitroglycerin, I think is a acceptable and beneficial practice. I wanted to demonstrate to you that the maternal experience is superior both in terms of pain and how they rate their satisfaction if you do a neuraxial technique, including even the lowest dose techniques. But I wanted to convince you more than anything else that in employing this technique is probably one of the few ways you can, in your specialty, make an impact in what is a major public health crisis in the United States. That is the inappropriate rise in cesarean delivery rates. You actually can reduce them. The sum total of our experience in the United States in employing this technique shows that we reduce it by 9%. And it's probably cost effective. Thank you very much.